Bismillahirrahmanirrahim. I am Dr. Atika Masood. I am Associate Professor of Pathology in Akhtar Said Medical and Dental College. Today we are going to discuss the most important chapter of general pathology, and that is neoplasia. The Martin Luther King Jr. have once said, "The ultimate measure of a man is not where he stands in a moment of comfort and convenience, but where he stands at the time of challenge and controversy." For whole of the world, my dear student, this is the time of the challenge of COVID-19. And because of this, we have to stay at home to stay safe. In order to facilitate all of you, we have started the online teaching. So it's my humble request. Please give full concentration to your lectures and try to give your maximum. The learning objectives of today's lecture will be at the end of the lectures, my dear students would be able to define neoplasia, define dysplasia, and carcinoma in situ. You would be able to define and differentiate between the benign and the malignant neoplasms of both epithelial and the mesenchymal components, the nomenclatures and the classifications of the neoplasms of both neoplasms regarding the epithelial variants and the mesenchymal variants. So first of all, what do we mean by neoplasia? As you all know, neo means new and plasia is basically stands for the growth. So from the neoplasia we means that it is an abnormal mass of the tissue, the growth of which is going to exceeds beyond the boundaries, and this becomes uncoordinated with that of the normal tissue, and this uncoordinated abnormal growth is going to persist in the same excessive manner after the cessation of the stimuli, which is going to evoke that change. So, my dear students, just remember this thing. It is a new abnormal growth which is going to exceed beyond its border, and it is an uncoordinated growth pattern, and this will persist even after the cessation of the stimulus. In normal medical terminologies, neoplasm is often referred as tumor, and the study of tumor is called as oncology. In oncology, the or division of the neoplasm is into two categories. The first category is the benign component, and the second one is the malignant component. And basically, this category is done on the potential clinical behavior of the neoplasms. And by this we means that these benign tumors behave very innocently. So benign tumors are going to behave very innocently. They are laying there for months, for years, and they are not going to go beyond their boundaries. But the malignant ones, their potential clinical behavior is very aggressive behavior. So the aggressive behavior of malignant shows that within days this is going to increase in the size, and also this is going to metastasize to the other regions. As far as dysplasia is concerned, why, my dear students, we are going to talk about dysplasia? That, as you all know, that there is a progression in the cancer. From the normal epithelium, we have just seen its definition that from the normal epithelium, because of some stimulus, there is an uncontrolled growth, and this uncontrolled growth will remain uncontrolled and increase in the size will be there even after the cessation of the stimulus. So from the normal epithelium to the cancer, there are many phases. The first of all, we are going to talk about dysplasia. As far as dysplasia is concerned, dys means disordered. So disordered plasia means production. So disordered neoplastic proliferation is going to be termed as dysplasia. The changes that we are going to see in the epithelium of this dysplastic elements are loss in the uniformity of the cells, and also there will be the loss in the architectural orientation. So there are two types of things. One is the uniformity of the cells is going to be loose, and there will be also the loss of in the architectural orientation, and by this means there will be the loss in the polarity. These dysplastic cells are shown as B2B pleomorphic. By pleomorphic we means pleo means variation and morphism means morphology in size and shape. So variation in size and shapes are going to be seen in the dysplastic cells. Some are very large cells, while some are very small cells, and in these cells there is large hyperchromatic nuclei, abundant mitotic figures because they are actively engaged into the going into the cycle for the increase in the growth pattern. So there will be the abnormal mitotic figures, and mitosis in the abnormal locations are also seen. The dysplasia, whether it is a mild or moderate or severe, the good thing is that this is totally a reversible change and it can revert back to the normal. After the dysplasia, the second category is carcinoma in situ. When this dysplastic changes is going to involve the entire thickness of the epithelium, then this is going to be called as carcinoma in situ. This can progress to the cancer or this can't progress to the cancer, it will remain there. And sometimes we can see it adjacent to the malignant foci also. So by dysplasia, we basically means that there is an increased degree of the disordered growth or the maturation of the cells or the tissues are often thought to proceed before the neoplasia. So dysplasia is a reversible process. Just remember this thing. Dysplasia is a reversible process, but once there is a progression or the transformation to the neoplasia, then this is an irreversible process. Then this could not be reversed back. So there is a natural history from the metaplasia, which is change of one cell type into another cell type, to dysplasia, and then to the neoplasia. And we are going to call it as progression. So this progression is basically from the metaplasia to dysplasia to neoplasia, and you can see this progression into the uterine cervical dysplasia because of the human papilloma infection, and also this we can see as in the respiratory epithelium after the cigarette smoke, after the irritation into the bronchiolar epithelium. The change is evident as squamous metaplasia and then further as a squamous cell carcinoma. Now we are going to show you the diagrammatic representation. Here you can see the very much normal cells, and after these normal cells we are having the totally dysplastic epithelium. If you are seeing here, the cells are very much normal columnar cells having the exactly same shape and same size as I have drawn for you, and these are going to have the same nucleus, and C ratio is totally normal. But if we are going to go into the dysplastic category, here you can see that all of the cells are of different shapes and the sizes. Some are bigger, some are larger, some are elongated, and some are polygonal. And in these, the nucleus is also going to be bigger in size, and in some categories we can have the mitotic figure also. This is going to proceed into the carcinoma in situ. And in carcinoma in situ, the whole of the epithelium upper than the basement membrane is going to be changed into the highly dysplastic pleomorphic cells, in which you can see that NC ratio is totally disturbed. We have a much bigger nucleus, and in these nucleus, nucleoli is sometimes also prominent, and also you can see here that we are having the abnormal mitotic figures are also present there. So these mitotic figures and these cells are present, and they are not breaching the basement membrane. But once these cells are going beyond the basement membrane and they are going to breach the basement membrane and going underneath, then it becomes the invasive carcinoma. So this is the whole progression from a normal epithelium into the invasive carcinoma. Here this is a diagrammatic, first we have seen the diagrammatic representation. Now I am showing you the histopathological picture. Here you can see this is your totally normal epithelium, and this is the squamous epithelium. In the lower section you can see that they are slightly cuboidal cells, and as we go up the cells are going to be flattened out, and in upper layer we have a keratin layer. Here you can see that these lower epithelium cuboidal cells are going upward, and in them you can see a slight pleomorphic changes are also seen, and a bigger cells are seen in the upper layer, and we can see that in these cells the NC ratio is slightly disturbed. In this picture you can see that there is a hyperplastic type of epithelium. The cell number is also been increased and their size has been increased, and here we are having the disruption in the epithelium is also seen here. We have few mitotic figures and there is a loss of polarity. Here you can see in whole of this epithelium there is a loss of polarity, loss of uniformity in the cells. So this is going to be called as high-grade dysplasia. And if these cells are going to be present in whole of the epithelium, but they are not breaching the basement membrane, here you can see that the basement membrane is still intact. I'm drawing for you people, and here you can see that none of the cells has gone underneath the basement membrane. Then this is going to be called as carcinoma in situ. Once these cells has breached the basement membrane, here you can see they have breached the basement membrane, they are going beyond the basement membrane, so the invasion has started. We have just seen that the malignancy has been started, and this is going to be called as squamous cell carcinoma or invasive squamous cell carcinoma. Here we have another picture. Here you can see that we have a totally normal epithelium, and here in the histopathological picture totally normal squamous epithelium, but here we are having these few dysplastic cells. Here this is the dysplastic cell, these are your dysplastic cells, and these are seen in the upper surfaces also, but this is the normal picture. But if these dysplastic cell is going to occupy whole of your epithelium, then this is going to be termed as carcinoma in situ, but still there is no breach. The basement membrane is very much intact. Once there is an invasion beyond the basement membrane, and this is the invasive foci, the malignant cells are beyond the basement membrane, then this is going to be termed as carcinoma. So my dear students, we have just seen that there are two types of neoplasias. One is benign category and the other one is malignant category. Benign tumors are those tumors when their microscopic and gross characteristics are relatively innocent looking. So they are going to remain localized. They are not going to spread to the other sides. They are amenable to the local surgical remover and the patient survival is very good. So once the tumor remains to its normal size and this is not going to metastasize, this we are going to be called as benign tumor. The malignant tumors are collectively called in a normal clinical settings as cancers. The malignancy as applied to the neoplasm is reversed to the benign ones, and these are the lesions that can invade, that can destroy the adjacent structures, and the most importantly that are going to metastasize. They are going to spread and they are going to cause the death. All tumors, whether they are benign or whether they are malignant, are going to have two basic components. The one is the parenchyma, which is of the transformed or the neoplastic cells. And these neoplastic, transformed, benign or the malignant cells need the support. And this support comes from the host. And the host cells are non-neoplastic stroma, and it is basically made up of the connective tissue, blood vessels, and the inflammatory cells. Now we are going to talk about the nomenclature. As in the world, you are going to name everyone, just like you are naming your friends, you are naming your sons and daughters. We are giving the names for the identification. So like in tumors, we are going to give them names for their identification. So in a benign category, we are going to add the suffix of "oma" so they could be easily identifiable. And we are going to add this "oma" with the cell type from which the tumor is going to arise. I'm going to give you an example. If the tumor is going to arise from the fibrous tissue, then we are going to add the word "oma" or the suffix of "oma" with the fiber, so it becomes fibroma. If the tumor is arising from the cartilaginous tissue, then we are going to add the word "oma" or suffix "oma" with the chondroma, so chondromatous elements, so it becomes chondroma. So we have just done I've given you the examples of the mesenchymal tumor. Now I'm going to tell you about the epithelial tumors. The epithelial tumors, which are benign in category, is bit complex because these are going to be divided upon on the basis of their microscopic pattern, on the basis of their macroscopic pattern, or on their cell's origin. But I am going to make it very easy for you people. We are going to divide it into three categories. One is the adenoma. Basically, students, adenoma is all the benign epithelial neoplasms that are going to produce glandular pattern. What we are going to talk about? Glandular pattern. Here you can see the parotid glands, and these are your long columnar cells, and these columnar cells are arranged into a gland-like portion. So this is a glandular pattern. So these glandular pattern tumors are going to be called as adenomas. Here you can see that there are multiple glandular structure, 1, 2, 3, and the numbers continue 1, 2, 3, and we have lots of glandular-like component in which in the center we have a hollowed surface, and around this hollowed surface we have the lining cells of the locuboidal epithelium. And in between these glandular structure, the stroma is very less. These are lying just close to each other. So this component at this side of the slide is going to be called as adenoma. So you can easily call as the glandular structure which is benign is adenoma. So the other category after the adenoma is a papilloma. You can easily see papilloma. Papillomas are the papillary as the word comes from its name, papillary projection. Here in these pictures you can see that on the tongue of this patient we have papilla like projections, and these are finger like projections you are also called at. These are not like only on the microscopic pictures but also in a microscopic pattern there are all finger like projections. So the epithelial is grown or thrown into the folds. So this is going to be called as papilloma. Now the third category. The third category is a polyp. Polyp means that there is a mass that is going to project above a mucosal surface. Here this is a mass that is going to project above the mucosal surface. Here you have normal intestinal fold here. Here you have normal intestinal fold, and between these two normal intestinal folds you are having a projection from this mucosal surface, and on this mucosal surface we are having the epithelial lining. So we are going to call it as polyp. And here you can see these are normally seen in the intestines, and these have the stalks. This is going to be called as stalk. So this stalk is the area from where it is projecting upward. Here you can see here again, this is the polyp, and here this is the HND picture of the polyp or the microscopic picture of the polyp. Here you can see that this is the stalk and this is arising from the normal mucosal surface towards the upper side. So we have just done the benign things. All the mesenchymal benigns we are adding the words oma, and for the epithelial we have used three terms: papillomas, polyps and adenomas, depending upon their microscopic, macroscopic or their patterns or their cells of the origin. Now we are going to do the malignant counterparts. The malignant counterparts in form of mesenchymal tissue or its derivatives are called as sarcomas, while for the malignant neoplasms of the epithelial cell origins are going to be called as carcinomas. I am giving you an example. If we are going to talk about the mesenchymal malignant counterparts, then we have just done that if it is benign and it is going to originate from the fibrous tissue, in cases of benign it is going to be called as fibroma, but if it is malignant then it is going to be called as fibrosarcoma, because we are adding the word of sarcoma with the origin of the tissue, and if it is originating from the cartilaginous tissue we are adding the word of sarcoma with the chondro, so it becomes the chondrosarcoma. Now we are going to do the classifications of the benign and the malignant tumors depending upon their parenchymal cell types. If they are having one parenchymal cell types, the connective tissue derivatives are going to be divided or classified as, if it is originating from the fibrous department, then it is going to be called as fibroma, and the malignant counterpart is going to be called as fibrosarcoma. If it is originating from the fat tissue, for the fat we are using the word lipo, so it becomes from the benign category lipoma, and for the malignant category liposarcoma. For the cartilaginous benign tumors we are having the chondroma, and for the malignant one we are having the chondrosarcoma. For the bony tissues we have in the benign categories we are going to name at osteoma, and for the malignant category osteogenic sarcomas. So here you have seen that all the connected tissue derivatives are in the malignant categories have the suffix of word sarcoma, while in the benign categories all of them are having the suffix of oma with the tissue that they are going to arrive from. So this is very easy. In the endothelial and the blood related tissues, if we are going to talk about the blood vessels, it is very easy for you people to remember. Again we are adding the word oma, so it becomes hemangioma. And if it is malignant, then we are adding the word sarcoma, so it is angiosarcoma. For the lymphatic blood vessels, it is lymphangioma, and in the malignant category, we are having the sarcoma. While for the synovial tissue, we are having only one category, and that is the malignant categories, and this we are going to call as synovial sarcoma. Now, we have one misnomer. Misnomer means that we have given the wrong names. As I have already told you that this oma stands for this suffix stands for the benign counterpart. Once the mesothelial lining tumors have been defined or identified, the people at that time thought that these are benign tumors. But later on, they showed that these are the malignant ones. So mesothelioma is a word which is a misnomer. It is a very, very malignant tumor. So just remember this thing. Sometimes MCQ comes and they are going to ask you that what is it, a misnomer or is it a benign tumor? So just remember this thing. Mesothelioma is a totally malignant tumor, and this oma suffix is not right in this category. Now we have meninges, and in the meninges we have benign counterpart as meningioma, and in the malignant category we have invasive meningioma. Again oma is there, but we have added the word of invasive. As you all know that in benign category there is no invasion. So malignancy, in the malignancy, the invasion is the most important thing. So for all the hematopoietic cells, we are going to use the word leukemias, and for the lymphoid tissues, we are going to add the words of lymphomas. Again, a big misnomer. Lymphomas are highly malignant tumors. You must have heard Hodgkin's lymphomas or non-Hodgkin's lymphoma. Again, a misnomer. When these are discovered, people thought that these are totally benign. So this is the old name and it is still used. For the muscular compartment, we have smooth muscles, and for the smooth muscles, we are going to call them leiomyoma, and for the malignant, we have leiomyosarcoma. For the skeletal or striated muscles, we have rhabdomyoma and rhabdomyosarcoma. As far as tumors of the epithelial regions are concerned, I have already told you that in the malignant category, we are going to add the word carcinoma, and in the benign categories, we are having the papillomas, we are having the adenomas, we are going to have the cyst adenomas if there is a dilatation in the glandular structures. We are having other things like polyps in the intestinal canal also. So if there is a tumor of the epithelial region of stratified squamous epithelium, then it is termed as squamous cell papilloma, and in the malignant category we are going to call it squamous cell carcinoma. For the basal cell we do not have any benign component and it is basal cell carcinoma. For the epithelial lining arising from the glands or duct, we have also shown you the pictures of the parotid. So in the parotid we can have adenomas and adenocarcinomas, then papillomas, papillary carcinomas. Here you can see papillary carcinomas in the ovary, in the thyroid, then cystadenomas in the ovaries, and cystadenocarcinoma. Again we are adding the words carcinoma. So cystadenocarcinoma in the malignant categories. In the respiratory passages, bronchial adenomas and the bronchial bronchogenic carcinomas. The renal tubular adenomas and the renal cell carcinoma. Just like that, we have liver cell adenomas and hepatocellular carcinoma. In the urinary tracts, this urinary tract transitional epithelium is going to be converted into the papillary-like fronds, and so we are going to call them urothelial papilloma and the transitional urothelial carcinomas. In the placental epithelium, we are having the hydrated form mole in the benign categories, while choriocarcinoma in the malignant categories. As far as testicular epithelium is concerned, we are having a one category which is going to be called as seminoma, and again my dear students, it's a misnomer. We are having the suffix of the oma, but this is highly malignant tumor, so this is again a misnomer. Tumors of the melanocytes in a benign category is called as mole or nevus. You must have heard that there is a mole here, and you have to see its size and the shape. If there is any variation in the size and the shape, then we have to think about the malignant melanoma. So again it is a misnomer because we have added the word oma with the melanocytes, but we have added, in order to give it a differentiation, they have added the word of the malignant also with it. We have just discussed that these all tumors are arising from one cell type. Now we are going to discuss that there are more than one cell types, but these one cell types are going to originate from one germ cell. So more than one neoplastic cell types, but they are derived from the one germ cell. And in this category, the most important one is the pleomorphic adenoma, which is going to rise from the parotid glands or the salivary glands, and there is a difference in the shapes and difference in the variations of the glandular structures which are shown in the salivary glands. So this is going to be termed as pleomorphic adenomas, and in the malignant categories we have malignant mixed tumors of the salivary gland, because I have told you that they are originating from 1 to 2 more cell types. Then in renal cell we are having the Wilms tumor. In Wilms tumor we are having the 3 cell lineages. One is the epithelial, one is the mesenchymal, and the third one is the blast cells. So in Wilms tumor we are having the 3 components, and these blast cells can change into any of these compartments. Then we have a categories in which we have more than one neoplastic cell types, but they are going to be derived from multiple germ cells, like from a ectoderm, like from the mesoderm and the endoderm. So if they are originating from more than one ectoderm, mesoderm or endodermal lining, these are going to be termed as teratomas. And in the teratoma categories we have mature teratomas as the benign type and immature teratomas or the teratocarcinomas in the malignant categories. My dear students, at the end of this lecture I am going to give you 2 important MCQs, and these MCQs are for you people. Just to understand this, A 40-year-old man gives a history of passing blood in a stool. A colonoscopy is performed in 0.9 centimeters circumscribed pedunculated mass on the short stalk is found in the upper rectum. So this is the GI tract. This is a GI tract, and the most important thing is a short stalk and a pedunculated mass. Which one of the following terms best describes this lesion? Adenoma, carcinoma, choristoma, hematoma, or hyperplasia. Here for you people, there is another picture. Just I want to give you a help, or I want to give you a tip. This is a tubular adenoma. Here you can see that there are the gland-like structures, and these are the tube-like adenomatous polyp in which they are going to be present, and then there is a villus type, and in this villus type you can see that there are villi-like projections. So this is called as villus adenoma or villus papilloma, and here there is a combination. You have a tubular epithelium like here in the tubular adenoma, and like in this villus category you are having the villi-like projection. So this is going to be called as tubulovillus adenomas. So these are mainly three varieties of the adenoma. I hope so that this diagram is going to help you in solving the last MCQ. Now the second MCQ is a 23-year-old woman has noted a nodule on the skin of her upper chest. The microscopic appearance of the lesion shows composed of the numerous variable size blood vessels. So there is a hint for you people. Numerous variable size blood vessels. Which of the following neoplasm in this lesion is most likely to be fibroadenoma, hemangioma, leiomyoma, lipoma, and melanoma? This is very easy for you people. I hope you can easily do it. Thank you very much every one of you. Next time we will start with a few MCQs and the SCQ, and we are going to do the characteristics of the benign and the malignant neoplasm. Thank you very much everyone. Stay at home, stay safe.